Hello, it's 1:31, so we might get started. I'd like to begin by acknowledging the traditional custodians of the land from which I'm coming to you today, and I think Amanda and many others as well, the Ngunnawal people, and pay my respects to their elders past, present and emerging. So today we're very lucky to hear from Dr. Amanda Watson. And Amanda is a research fellow with the Department of Pacific Affairs at the Australian National University. Her research focuses on mobile telephone use in Papua New Guinea, including strategic uses and regulatory issues. Her PhD thesis looked at the uptake and use of mobile telephones during the earliest days of mobile telephone adoption in Papua New Guinea. Her work has been published in Mobile Media and Communication, Pacific Journalism Review, Media Asia, Australian Journalism Review, and elsewhere. So today the title of Amanda's talk is Telephone Hotlines in Papua New Guinea, a review of 3 research projects. So Amanda, we've got 30 or 40 or 45 minutes, however long you need for your talk, and then we'll have some questions at the end. So Amanda, are you good to share your screen there?
Yes, I will do. Thank you very much for the invitation to speak in this seminar series. It's a delight to be joining you this afternoon. So thank you very much for having me. So yes, I'll introduce the history briefly of telephones in Papua New Guinea, and then I'll outline these 3 published research projects about telephone hotlines in Papua New Guinea, and I'll conclude with reflections upon some theoretical implications, looking at communication scholarship and in particular the field of ICT for D, or Information and Communication Technologies for Development, and some policy relevant implications of these research projects, and I'll look forward to your feedback, suggestions and questions. So as most of you might know, Papua New Guinea, also known as PNG, is a developing country just north of Australia and west, or rather east, I should say, of Indonesia. There's limited media reach around the country, and many people live with limited or almost no media access. There's very limited electrification and very limited landline phone access. So it's not common for people to have a landline phone in their houses. Mobile telephone uptake in Papua New Guinea. This graph that I've created is starting from the year 2000, but really mobile phone access in terms of network coverage and uptake really only started in 2007 when competition was introduced to the sector. There are now 2.8 million mobile phones in use in the hands of 2.5 million individual users, because of course some people have more than one phone. Of those, about 600,000 are smartphones, so that's out of 2.8 million active phones. But what is the population of Papua New Guinea? Well, a very recent paper by 2 demographers, Michael Burke and Bryant Allen, looked at the question of the population of the country. Estimates range from 7.3 million to 9.6 million, and they think that the likely figure is somewhere between 8.8 million and 9.6 million people. So roughly a third of people have access to a mobile phone. The main company with most of the subscribers is a company called Digicel, which operates in the Caribbean, Latin America, and 6 countries in the Pacific. They have 2.5 million active mobile phone numbers. The other 2 providers have 300,000 users or active numbers between them, and they're going through a process of a merger. There's likely a new player to enter into the mobile space in Papua New Guinea by the end of this year. They're setting up at present, so it will be interesting to see if that has any impact. And the other thing is that in the news today, Australia's Telstra is looking at buying Digicel Pacific. That's Digicel's operations in 6 Pacific nations, including Samoa and Papua New Guinea. I'd just point out the lateness of mobile phone uptake and access in Papua New Guinea compared to many countries in Africa, Asia, Caribbean, Latin America, and so on. This graph compares Papua New Guinea with the Republic of Korea, or South Korea as we often call it, the dark line being Korea's uptake of the different generations of mobile phones. So 1 on the y-axis means 1G or analog phones, 2 means 2G or digital phones, and so on. Of course, the graph is a bit simplified by having these stages like this, but just to give you an idea, Korea had the first digital mobiles or 2G telephones in 1993, whereas Papua New Guinea had its first access to mobile 2G phones in 2004, but that was only in 2 cities, and most of the country didn't have any coverage until the competition started in 2007. In this graph, Papua New Guinea appears to have caught up to Korea, but of course Korea is moving up to 5G now, and also some parts of the network are still 2G and 3G in Papua New Guinea, so not all of the network is up to 4G in the country at present. So I'm going to turn now to talk about the first of the 3 telephone hotlines that I'll be introducing to you. So the first one, a maternal health telephone hotline that was established in 2012 in Milne Bay province of Papua New Guinea. Milne Bay province is a province with many inhabited islands, also coastal areas with no road access, as well as some very mountainous regions as well by the coast. This hotline was designed to address maternal mortality because Papua New Guinea has a very high maternal mortality rate, and in Milne Bay province, with the challenges of islands, coastal communities with no road access and so on, the maternal mortality was felt to be a serious problem. The hotline involves an emergency phone that's been placed in the labour ward at the hospital, in the main hospital in the province, and the labour ward is staffed 24/7 and the emergency phone has been put there. The telephone number was given to health workers around the province. They received stickers and posters with the number on it, as well as detailed information about when to phone, why to phone, and so on. It's a free call service, so health workers can ring it free of charge. They can call from any phone. They can call from their health centre or indeed from a patient's home or any location to the labour ward, which, as I said, is staffed 24/7. I was intimately involved with this project and was also the lead for a research project involving 42 one-on-one semi-structured interviews and group interviews to assess people's knowledge of and opinions about the maternal health hotline. Of the 42 interviews, 25 were with rural health workers based at health centres like the one I just showed you a photo of. 3 were with rural health workers based at aid posts, which are small, remote health facilities, usually only staffed by 1 person. The labour ward staff were interviewed in 2 rounds. 5 interviews were done at the outset of the project in 2012 and another 5 in 2013. These are key people because they're the ones answering the emergency phone, so that's why they were interviewed twice to get their impressions. Also a couple of interviews with women at health facilities and community leaders, 42 interviews in total. It's a qualitative research project, so we're interested in people's views in their own words. As one labour ward staff member said, it's easy where we can help give advice, and that advice is a fast help. That advice or instructions on how to attend to the emergency to those who do not have the skills or knowledge to attend to emergency cases such as retained placenta that needs a manual removal, we can help over the phone. A rural health worker said, before, I saw a mother die in front of me because of no communication. Today, anywhere I can call and it's free. I don't need to spend any money and it's very good. I'm really happy. And we heard quite a few stories from health workers about women who had died before the hotline was established. There was an extraordinary story, in fact, of one health worker who used the hotline within 24 hours of finding out about it. As this person said, straight after we got this information about the free call to the labour ward, I had this retained placenta. In other words, a patient with a retained placenta. And I went. For 3 days, this mother was, the placenta was retained. So the health worker travelled to the patient where the patient had been in this situation for 3 days. And when I went to the clinic site, in other words, to where the patient was, the worker goes on, straight away from there, I talked to the labour ward staff and I got advice about what to do. Had I not, if this project was not here and I didn't have any means to communicate, we could have lost this mother because she was already septicemic. So I find it very helpful. It's very good. From anywhere, any point, I could seek advice, very isolated or what, I could seek advice and I can help the patients. So through the interviews, there were various stories about patients' lives being saved, and there's more details about that in the journal article. The hotline was established with funding from Australia, which included the funding for someone to travel around the whole province to make sure that health workers knew about the hotline, as well as the funding for the travel for the interviews. And it was conducted in partnership with the Milne Bay Provincial Health Authority. And as is shown in this photo, it was handed over to the authority, which then continued to pay the monthly phone bills themselves. Writing in 2019, so 7 years after it was established, the Milne Bay Provincial Health Authority's head, that's Billy Nidey, who's pictured in the black jacket in this photo, he wrote in 2019 that the hotline, with other initiatives, has made a significant contribution to reducing maternal deaths, almost 60% in the last 5 years, and the hotline continues to operate to this day. So now I'll turn to the second hotline that I want to tell you about. This was established by Western Highlands province of Papua New Guinea. They established this call centre, a health call centre in 2015, staffed by nurses 24/7, a team of nurses who were hired specifically to answer calls in a call centre. The logo for the project was long, designed to fit on mobile phones commonly in use at that time, like this Nokia phone pictured here. Like with the previous research, health workers, like with the previous hotline that I talked about, health workers could use the health call centre in Western Highlands province, but unlike the other one, this one was also open to the public. Nurses answering calls were in a telecommunication company's call centre, not in a clinical setting, but sitting in the call centre waiting for calls to come in. The health call centre had 5 functions that it was designed to address: health advice and information for members of the public, emergency medical evacuation requests from the public. So if the public felt that they had someone that needed to be transported to a hospital by road or helicopter, then they could request that through this phone number. The public could provide feedback regarding health services, and I know the head of the health authority was quite excited about that prospect. Advice to rural health workers. So this was a separate phone number that was given exclusively to health workers, so they could call to get advice from the nurses, and if need be, the nurses could seek advice from specialist doctors at the main hospital. And fifthly, it was hoped that the health call centre could be a help with the reporting of maternal and neonatal deaths, to try and improve those statistics by getting that information both from the public and from health workers. So it was complex, particularly in terms of trying to get messaging out about the call centre, because it had these 5 different functions. So I was involved in this project as well, and also involved in looking at some analysis of the data in terms of the calls that coming into the call centre. The journal article that's referenced at the bottom of the screen reports on data from the first 9 weeks of the call centre's operation, and today I will also tell you what happened after that initial period. So during that initial period, there was a slight increase in utilisation of the service. In fact, it started late in January, so that's why there's not many calls there, January 2015. February, most of the calls were prank calls or inquiries about the service. Typically, people were finding out about it by receiving text messages or SMS, short message service messages on their phones, and then ringing up to inquire about the service. In March, there were more calls overall, and about a third were health related, a third were prank calls, and a third were general inquiries trying to find out about the service. So during this 9-week period, there were 113 health-related telephone calls. Most were from the public and a small number were from rural health workers. So as I've said, there were prank calls and calls inquiring about the service, which is of course quite natural because the SMSs, the text messages were very short and people were calling up to get more information. So in that 9-week period, 38% of the calls were prank calls, 38% were inquiries about the service, and just under a quarter were health-related calls. Now I have some additional data which is not in that published paper. This is the calls received during the calendar year 2015. The graph shows health-related calls, not the other calls. The centre still received prank calls and inquiries about the service, but they're not included in this particular graph, which is just showing health-related calls. The graph shows the gradual uptick in January to March that I've mentioned, and then variation in the number of health-related calls received each month in the first year of operation. In total, in that year, there were over 8,700 calls to the Health Call Centre, with most of them, 88%, not being health-related. There were just over 1,000 health-related calls. The spike you can see in August is because there was an official launch of the Health Call Centre in August, at which the media was in attendance, and there were various media interviews in the days around that as well. So radio, newspaper articles, I think there were also some extra text messages went out at that time. In 2016, the calls were at consistently low levels, like the months here, but not apart from the spike. So what happened to the call centre? Well, the call centre closed in October 2016, so less than 2 years after it had started in January 2015. And why is that? And I'm going to go into some of the reasons that I think there are, although further analysis is probably required. But in my view, it was a bit too complex and too ambitious and also too costly. And I'll explain about that. In the conclusion of the paper, which I should say I also wrote that with one of the managers from the Western Highlands Provincial Health Authority, in the conclusion of the paper we said the value of health phone lines in Papua New Guinea has been demonstrated with the implementation of a simpler model in another province, and that's referring to the maternal health hotline that I talked to you about already today. Nonetheless, we wrote, this project has more ambitious aims in terms of improving not only health system efficiency, but also health-seeking behaviour. One of the major concerns that the Health Call Centre was trying to address was an issue regarding health-seeking behaviour. People in Western Highlands Province tended to not contact the health authorities, tended not to go to medical professionals until their sickness became so severe that perhaps it was too late. So they were really trying to get people to get more engaged with the health system and with looking after their own health and being in touch with the health system more often. In the article, we went on to write the previous project focused on maternal health. That's the one I talked to you about first, whereas the current project incorporates all types of healthcare. Indeed, the scope of the second project was much bigger, I would suggest, and I've put together a table to show the scope of the two projects. The first column looks at the maternal health hotline in Milne Bay Province that I talked to you about initially, and the second column, the health call centre in Western Highlands Province. So as I just said, one of them was focused on maternal health, whereas the second one focused on all kinds of types of health, including snake bites, childhood illnesses, all sorts of things. The first one was only available for health workers. The phone number was only given to health workers, whereas the second one was open to the public as well. The first one, calls were handled by existing staff in the labour ward at the hospital, whereas the second one, nurses were hired. A team of people were hired to answer those calls. The first one had very specific and narrow aims, whereas the second one was complex with 5 different functions it was trying to achieve. The first one had just 1 phone number, whereas the second one had 2 phone numbers. This table looks at the outcomes and the status of the 2 services. So as I've said, the Milne Bay Province Maternal Hotline is sustainable and is continuing to this day, whereas the second one lasted less than 2 years. The first one continues to be valued by the health workers in the health management, as well as the labour ward and the rural health workers, who very much appreciate it. The second one, during 2016, the call centre committee stopped meeting. The call centre committee consisted of representatives from Australia, because the health call centre was funded by Australia, and also various people from Western Highlands Provincial Health Authority and the telecommunication company. Also in 2016, awareness activities ceased and there weren't a lot of phone calls coming into the health call centre for that reason. Costs, the first one costs the Milne Bay Provincial Health Authority about 700 kina per month for the incoming calls to the hotline in the labour ward, which is about 250 Australian dollars. The second one was much more expensive because the team of nurses had to be paid to work the shifts. Night and day, over the weekends and so on. The first one we published quite detailed research, whereas the second one we only published that early research so far. And in the case of the maternal hotline, the Milne Bay Provincial Health Authority's doctors and management team have done their own research, which has been presented at the country's medical symposium as well. So the 2 services are quite different regarding their functionality, scope and purpose, as I hope I've been able to explain. Yet a comparison of the 2, I think, provides some understanding of the roles of health telephone services in a country with poor health indicators and stretched health services such as Papua New Guinea. There's differences between the projects, and I would suggest that a simple targeted intervention can save lives. And in the case of the maternal health hotline, we know that it did save lives and has had numerous positive results, including in the relationships between the health workers at the hospital and the rural health workers. And we wrote about that in the paper. However, a complex, costly project was unsustainable. I think that this can provide some lessons for health phone services in the Pacific region, and I'd suggest they need to be well planned, budgeted for and managed. I'm going to talk briefly about a third hotline before going to theoretical and practical implications. The third one is in the Autonomous Region of Bougainville, which is in Papua New Guinea. The Autonomous Bougainville government established a telephone information hotline that operated for 8 weeks in 2019, just before polling in a referendum. As I said, it was implemented by the Autonomous Bougainville government, but funded by a development partnership of Australia, Papua New Guinea, New Zealand, and the Autonomous Bougainville government. The service was launched with a robocall that was a phone call to the phones around Bougainville with a recording of the then president's voice. There were also weekly text messages informing people about the hotline, informing them that the audio messages changed weekly and encouraging them to ring. So the hotline was a well, you could call it interactive voice response, or IVR, for those who know what that is. Basically, it was a toll-free or free call number with 4 options. So people could press 1 to hear one set of audio recordings, 2 to hear another set, and so on. The audio recordings were done in Tok Pisin, which is a language spoken widely throughout Papua New Guinea, and the messages changed weekly. So I was involved in a research project. I led a research project involving 8 group interviews to assess people's knowledge of and opinions about the telephone hotline towards the end of the 8 weeks of its operation. The group interviews were done in Tok Pisin, which, as I said, is a common language there. And the interviews were done in all 3 regions of Bougainville, including some groups just for women. So turning to the qualitative results, 17 of the 42 people in the group interviews were not aware of the hotline. They hadn't heard of it. As one person said, for the phone service, I can say we do not get it here. We do not have this service here, this phone service. We do not know about it. I was also surprised when I saw it here. pointing to the information sheet. So there were people in the group interviews who had never heard of the information service, even though it was available, and yeah, they just weren't aware of it. 12 of the 42 people were aware of it but had not used it. As one of the people said, sometimes we're busy. I just look and I say, oh, one message. Then I go wash a piece of fabric or something like that. Oh, I will cook first. When I cook, I forget. So there were people like that who knew about it but hadn't used it. But others had heard the audio messages. As one group member said, my father, every day he puts this referendum awareness, he turns it on, and I tend to stay outside or stay outside of the house, or I stay in the kitchen, or I'm busy near my father's room, and I tend to hear. All talk comes on the phone on the referendum. There was another example as well I'd like to share with you of people hearing through other people's phones. In this case, people set up a solar system, connected it to a speaker and played the messages from a mobile phone repeatedly through a speaker in a community, and people gathered around to listen. So those two examples show that people were listening even if they didn't have phones or not necessarily listening from their own phone. And that's good to know that people without phones were able to hear the messages, but also there was evidence that people were able to hear in places where there was no radio station signal, and they were able to hear through their own phones or through other people's phones. Indeed, the issue of radio station signal came up really strongly in the group interviews, even though that wasn't something that we were necessarily finding out about or trying to find out about, particularly in South Bougainville, where there's no radio station signals, and people were very emphatic in the group interviews that they want to have access to radio stations. Turning now to the theoretical implications of the 3 hotlines, and I'm going to mainly talk about Richard Heek's work because I think that's a helpful place to attack this from. Richard Heeks in 2009 came up with his manifesto looking at ICT for D, or Information and Communication Technologies for Development. In ICT for D 1.0, which is what he saw as an earlier stage of development and which is demarcated by the rectangle in the diagram, he said that was about provision of technology, for example, the establishment of telecentres in developing countries, most of which he argued had failed. ICT for D 2.0, he suggests, is a better evolution or a more advanced evolution of ICT for D, and it's about responding to user demand, user needs, and user perspectives, and trying to achieve development outcomes. He thinks ICT for D 2.0 is less about introducing new technology and more on trying to use what is already in use, such as mobile phones and radio. Of course, the line in his diagram is a dotted, wavy line, bendy line, suggesting it's not necessarily a fluid, or, well, it's more fluid and not necessarily a linear process. The manifesto by Heeks in 2009 argued that however well motivated the original ICT for D movement, which he called ICT for D 1.0, was grounded in a technocentric approach focused on ICT innovations, an invention-down approach bringing new technologies into development contexts. Instead, the new form of ICT for D, what he called ICT for D 2.0, should focus on a bottom-up approach, shifting the balance from technology invention to technology use. So the shift is from desktop computers in telecentres with CD-ROMs to things like mobile phones and radios that people might already have. He said, rather than wait for handset or bandwidth upgrades to allow mobile internet, what could be achieved through telephone calls and text messages? And I think these examples show that things can be done with telephone calls and text messages. So Heeks was on about using the technology that people have rather than introducing new technology or thinking about the fanciest solution. Simple is best. And he argued in his manifesto that mobile phones are key. Last year, 10 years on, Heeks revisited his notions and coined the term ICT for D 3.0, or digital for development. So he's now suggesting a change in terminology from thinking about information and communication technologies to thinking about the digital. Heeks suggests that since 2005, digital ICTs have moved from a peripheral to a core role in developing countries. He says that some aspects of ICT for D 2.0 remain important, including the need to gather the perspectives of the target people and communities for whom development projects are intended. However, ICT for D 3.0, or Digital for Development, conceptualizes ICT not as one tool among many that enables particular aspects of development, but as the platform that increasingly mediates development. So how does this theoretical basis relate to the 3 hotlines in Papua New Guinea? Well, in terms of Heeks' typography, the 3 hotlines were not ICT for D 1.0 projects, I would argue, because they did not involve the distribution of technology. The hotline projects did incorporate, I'd suggest, some of the recommended strategies suggested by Heeks in relation to ICT for D 2.0. For instance, he recommended that project design take into account the needs and perspectives of users. The 2 health hotlines I introduced were driven by doctors passionate about addressing health issues that they were deeply concerned about, maternal mortality in one case and health-seeking behaviour in the other case. Also on this idea about seeking user perspectives in design, I'd suggest that the project in Bougainville did this as well, because it aimed to address identified information needs, and the writing of the audio message content for the hotline was in response to frequently asked questions from people around Bougainville. At present, access to information and communication technologies, mainstream media and electricity remains generally limited across much of Papua New Guinea, including Bougainville. Therefore, to me, Heeks' 2020 notions of digital ICTs having become central to people's lives and development efforts seem somewhat irrelevant in the setting at present in Papua New Guinea. So therefore, I feel there's quite a lot of benefit from the Manifesto, and there's some interesting things in his more recent writings, but it does somewhat, to me, seem out of kilter with the reality on the ground. And are there any practical or policy relevant implications? Well, toll-free hotlines, I would suggest, can be valuable in places where people do not have much money and they can ring free of charge, but obviously the projects need to be managed well. There's no silver bullet. Hotlines cannot solve all communication and information problems on their own. For instance, a couple of the projects, well, all of them really had issues about how we could promote and inform people about the hotlines. You know, so therefore you need to use other communication strategies as well. So they can't stand alone and solve all problems on their own. I'd like to thank those who've joined today and thank again the organisers for the invitation to speak in this seminar series. I would also like to acknowledge my co-authors in the research projects and the various organisations involved in funding and establishing these hotlines and allowing me to be involved on the research side. So thank you very much, and I look forward to the discussion. Thank you.